Hello, besties. This is Christopher Tolisano at Best Day Fitness Studio, and I have a special guest today. This is Dr. Tonya Olson, and she is our in-house physical therapist here at Best Day Fitness. And I just wanted to introduce the world to her and also kind of go over today what we're going to be talking about. Best Day is working on a collaborative platform, which will bring health and wellness practitioners together to make sure that the clients and patients are getting a comprehensive program, multidisciplinary program where the treatment times will be decreased and overall costs will be lowered because the treatment times will be lowered as well. So, we brought Tonya in to talk a little bit today about insurance-based physical therapy and cash-based physical therapy models and the differences between the two and why we are opting into a cash-based out-of-pocket model with our treatment plans, and going forward with our collaborative platform, it'll be all cash-based. And Tonya's going to talk a little today about why we chose to do that, the data behind it, some of her experience working in insurance-based versus cash-based physical therapy programs. And I will first like to introduce Tonya. Hello, how are you doing today?
I'm fantastic. Having the best day ever.
Yes. Awesome. Yes, and actually, I met Tonya at a health and wellness fair, and her colors struck my attention because her colors and my brand colors are the same. I'm not wearing my turquoise today; I'm wearing my blue. But so we were just chatting, and we both kind of decided that we are like-minded individuals when it comes to healing humans and trying to do that as quickly and safely as possible. So we have collaborated ourselves and working on bringing on more health and wellness practitioners into the fold. Tonya, tell me a little bit about your past, how you came to be in St. Petersburg, where you were before this, and what you have been doing with your life.
Yeah, well, there's a lot to unpack, but I'll keep it kind of short and succinct. And if we need to expand on anything, we can always do that later. So I'm a physical therapist, and before moving to Florida, I lived in the Pacific Northwest. And my career as a physical therapist started off as being a PT assistant back a long time ago. I'm not going to tell how long ago, it was a while back. And as a PT, I've worked in across the board in all settings, from outpatient to inpatient, acute care, home health. And about a year and a half ago, I started my own cash-based mobile PT practice. My experience in general is a little bit non-traditional, but I actually moved here to Florida to help start a PT assistant program. That was an innovative, hybrid, accelerated model. And once we got that up and running, that's when I had the freedom to be able to start my own business where I could provide the high quality care without being constrained by insurance companies. Which is probably one of the most frustrating aspects of being a physical therapist, is constantly fighting with insurance companies who are essentially trying to, telling you how to practice. Even though I have a doctorate in physical therapy, I am the expert. And to have somebody who is not, the insurance companies, it's now in today's day, folks realize that they dictate a lot of the care that people get. But
So
years ago,
how does an insurance company dictate the care? Like, in which ways?
Well, yeah, in the insurance-based model, it depends on the insurance company. They can dictate, they can require pre-approval for the services that you get. Like historically, physical therapy services were offered, there was the gatekeeper model before the doctorate in physical therapy was required as an entry-level degree as of 2015. That you had, if you wanted to go to a PT who's the musculoskeletal expert in the healthcare, in the medical model, you needed to go to a physician, like a medical doctor first. And the model historically has been that physician then, who has training, a broad scope of training, would rule out any non-physical therapy related issues that the patient could possibly have, such as if somebody has low back pain, that could be something happening with the kidneys, or with something more serious that's non-musculoskeletal. So historically, physical therapists weren't trained to be able to differentially diagnose as to whether a person belonged in the PT clinic. But with the advent of the doctoral level education, we are now in that place, and the vast majority of states in the United States offer direct access to physical therapy. And each state has a little bit of a different practice act. And so that's actually something we forget to talk about, is that people can come, if you have a musculoskeletal injury, you no longer have to go to the MD to get a prescription. You can go directly to your physical therapist. And this is where insurance gets in the way, because some insurance companies still require that gatekeeper model, which increases your costs, decreases your access to quality care, et cetera.
Cool.
I kind of got off topic about my experience.
That's okay.
But anyhow.
Yeah. So, so you moved here and opened up that helped open up the
PTA program.
PTA program. Yeah.
Yeah.
Cool. And then you went out on your own doing mobile, just like in homes and stuff.
Yeah. So mobile PT practice, I just, part of it was not wanting to be married to a space, and having the freedom to be able to kind of see where my expertise or like where my niche market would land. And so, I will, go to people's houses, meet people at their gyms, meet people at the park, which is wherever is convenient to them. Go to their offices as well. I lived in the San Francisco Bay Area for a couple of years before moving to Florida. And in San Francisco, that model of bringing the services to offices is actually really common out there. And that's a little bit of what kind of my thought process was when I started my own practice, because it's, the traffic in downtown, San Francisco is really difficult. And so people being able to go out and go to the hairstylist or the nail salon or physical therapy or even personal training, they bring them in-house. So a little off topic, but that's a little bit of kind of what I was thinking. And then, cool. It's looking like what we're doing here.
So what would you say your specializations lie in, or is there a specific demographic that you've worked more with, or are you kind of working with lots of different people?
Yeah, that's really interesting. So I'm board certified in orthopedics, and fewer than 6% of physical therapists in the country have gone through that extra level of specialization. So that means that I went through, I basically took a really hard exam and I passed it.
Cool.
But in the process of taking the exam, you need to go through current best practices. It's very evidence-based, like current evidence-based. And so really beefed up my training as far as critically appraising research and becoming very familiar with the current evidence as far as treatment interventions, which I think a lot of folks it's easy to lag behind in current evidence. And so I'm board certified in orthopedics. And so which means a typical board certified in orthopedics physical therapist will work exclusively in the outpatient setting. And that's where you drive to the PT clinic. It's probably what most people think of as physical therapy. But I actually my experiences are very broad and comprehensive. I've worked for almost 5 years as a traveling physical therapist. And a lot of the settings that I would be in the inpatient setting in skilled nursing facilities, a little bit of hospital work, but also home health, and so I have a very strong, there's not really, other than pediatrics, I would say that I'm an expert in all physical therapy in all settings based on my experience.
Good. So well-rounded, lots of different.
Yeah. So that would be my strength.
And
inpatient,
outpatient.
Yeah. So my area of expertise is humans.
I like that. Yeah, me too.
Yeah, and that's where you and I have so much in common.
Yeah.
Because you have the similar, We a little in our niches or in our training, we have had a similar path. Whereas an athletic trainer is primarily outpatient, orthopedic, on the field, working with with an orthopedic physician type model. That's kind of where the athletic training um, base of knowledge is. But you've found your way into the stroke rehab kind of neuro stuff, which is really interesting. So we share that same, good care is good care if you have the same principles and foundations upon which you base your decision-making process.
Cool. Yeah. So it sounds like you've seen a lot of different situations, and you've worked in a lot of different places, which is great. I have similar experiences working lots of different populations, and it's allowed me to have a better grasp of the fundamentals of human movement. If you kind of see all the different versions of ways we can get injured, and whether it's a neurological injury or a physical injury, and then kind of being able to design programs based on your experience to speed up the treatment times based on working with all the different types of people. It allows to kind of, oh yeah, well, we all have the same types of feet, and we all have knees and hips, and the connections between the brain and the muscle are still there. Sometimes they're a little slow or a little damaged, but putting it all together and working with anybody that walks in the door that's a good experience level to have for sure. So we were talking about the different types of programs you've worked in, and insurance being the provider for the reimbursement for your sessions versus a client or a patient paying out of pocket. And that's kind of what our topic of discussion is today. And I, as a practice, have always been cash-based and know that I don't have a guarantee that I'm going to get paid next week from insurance. So I have been kind of having to try to heal people as quickly as possible to show them, hey, this is what I can do for you. I'm no guarantee to be able to see you for 6 weeks because your insurance is going to pay for it. So I understand how treating people hands-on is super important. So in your experience working in insurance-based models and cash-based models, how could you maybe just summarize the places you've worked at that are insurance-based and the places that are working on your own as a cash-based model? What are some of the major differences that you've seen in let's say like treatment times, out-of-pocket expenses for, with co-payments and everything with insurance? For example, I had shoulder surgery last year, and I was paying $60 a session for co-payments, and insurance basically was going to cover me for like 60 sessions, which is great. Like, wow, 60 sessions of coverage over the next year, but at $60 an hour out of pocket for me, and insurance is covering the difference. That was quite a bit of money for the orthopedic center where they were doing my PT. And then out of my pocket was a lot of money. So there's a lot of money being changed hands in the whole process with the insurance model. So ultimately I'm not good at math, but I did about 30
A lot.
sessions, maybe
Oh
30
shit.
times 60 was my out of pocket. So that was
That's
$1,800
$1,800.
is what I was paying over the course of probably 4 or 5 months. So yeah. So what have you, I guess just maybe set up a little the differences between the two from what you've seen, when it comes to, what the patients are paying out of pocket and what the differences in treatment times are. Sorry, that was a little long-winded,
No,
but,
that's okay. I'll start, and then if I get off, you could just kind of redirect me if I get too
cool.
tangenty.
Sounds
But
good.
it's okay. So essentially the difference between insurance-based physical therapy and out-of-network or cash-based physical therapy is the insurance-based model relies on high volume, high frequency in order for the clinicians to be able to keep their doors open, because insurance companies reimburse at such a low rate that per patient, you're not making, that you're just, the clinic's not able to, because they're the ones who set the price, which is really backwards historically and currently. Insurance is such that it would be like you go to the car dealership, you want to buy a car. And instead of having the dealer who's providing the service setting the price for that car, you say, as the insurance company, I'm going to pay this amount, and dictating the price. So the model is, the reimbursement model and price setting model is backwards. So because insurance companies reimburse the people who are providing the billable units and the actual care at an incredibly low rate, and there's a whole story as to why that has come to play that we don't need to get into. Physical therapy clinics are forced to have high numbers of visits and a longer episodes of care per patient in order to be able to pay the bills. So typically in the outpatient setting, and I've worked in a number of outpatient settings, like in Eugene, Oregon. Just a little vignette on my clinical experience. I worked at a PT clinic that was, so Eugene, Oregon is Tracktown, USA, and it's just down the road from the Nike campus up in Portland, or just outside of Portland. There's a track club called the Oregon Track Club, and they're considered to be a feeder team for the Nike athletes. The PT clinic that I worked in Eugene, Oregon was considered, it was the exclusive PT providers for the Oregon Track Club. So I've gone everywhere from working with elite level runners to, inpatient post-acute stroke people. So that's a little bit about my clinical experience. But anyhow, so in the outpatient setting, the clinic manager will sit you down and say, we expect you to have between 9 and 11 visits. It depends on the clinic. Some will say like 9 or 11, 11 to 13. So anywhere between like 9 to 13 visits per patient per episode of care, which would be eval to discharge per patient. And then the frequency tends to be between 2 and 3 visits a week for that amount of time. So that's usually about like 6 weeks or so, depending on that patient. And then anything outside of that deviates from that, because that's considered to be kind of the sweet spot for reimbursement. So if I wanted to deviate from that, I would need to, for one, advocate for myself and my patient to my management at the clinic, because let's say I wanted to have a fewer frequency. It's usually if I wanted to space things out and have less, that's where I get the most pushback. And from the management. From the insurance companies, you get pushback from trying to get the visits approved. So let's say somebody has, because they've got their protocols, and they're based on data, and data is based on, it's a bell curve, but that only considers the middle part of that bell. It doesn't talk about the outliers. And so physical therapists, we're constantly fighting for those outliers. So let's say the data says that the insurance company says that this patient with this diagnosis needs 7 visits. Well, let's say I get that patient, they're more complicated, and they need to have 14 visits. Well, that insurance company, I'm gonna have to fight tooth and nail to get those extra 7 visits. And that can often cost the patient a great deal more time, effort. And then the other constraint is the amount of time you get to spend with the patient. The average outpatient clinic will allow for a 30-minute treatment that's with the PT, but they're billing for an hour, 45 minutes to an hour. So billing is like in 15-minute increments. So you're encouraged to bill 4 units per patient. So what that ends up looking like is you may see me, the physical therapist, the skilled individual that you came to, see me face-to-face or as close to face-to-face as possible for that 30 minutes. But then another 15, you be being seen by a support personnel, like a PT assistant or PT aide, who hopefully is highly trained, like the ones that I'm accustomed to working with. But they're still that's billed under your physical therapy visit. And then another 15 for something that's maybe unskilled, but and so you're forced to have to spend that amount of time per visit, but really only spending 30 with a skilled professional that you're coming in with. So okay, where else do I need to go? I think that
So yeah, no,
I
yeah,
got
and so
that.
the fifth, so you're getting 30 minutes of time with the skilled professional, and then another 30 minutes with potentially a gray area.
Unskilled.
Maybe somebody good, maybe
Yeah.
somebody bad.
And I'm,
What
yes.
about like I know I would have like 15 minutes of heat on my shoulder, or 15 minutes of ice afterwards, or I mean, and I know those are they feel good and they're potentially have some benefit in some cases, but I could do that at home, and why do I have to pay for that? Things like that.
Right. And technically heat or ice is not billable, but if you add a modality to it, such as the interferential, the tens, then you can bill for it. It's like $7, but still it's better than nothing.
Right.
And then you do have, like, some patients really love that and they want that because it's kind of that it's kind of like a warm down. It's kind of like a little time to just, a lot of people have crazy lives and they want that 15 minutes of just hanging out. But somebody like we don't give them the choice. And that's one of the big issues with the insurance based versus the out of network or cash based, is the choice is taken away from not only the doctorate. I am a doctor in physical therapy. I have doctoral level education. I know what is best for my patient, and I should have the right to decide with my patient what they need to be doing per visit based on their unique circumstances and their unique preferences. So from that example that you just said, let's say you're a patient and you're in my outpatient clinic and you say, I don't want to have that heat or ice at the end of my visit. I may say, okay, you have a right to refuse that. That's fine, carry on. But I'm going to get a talking to by my manager, because they're going to say, now you're missing a unit per visit. And they're not being jerks. They're just trying to pay their bills.
Yeah.
And so really what the cash-based out-of-network model allows is for that choice. It's for the expert to be, and the patient who is their own expert. They're the expert for their own selves. For the two experts, the patient and the caregiver, or the professional, to be able to decide what is in that patient's best interest and how best to do things. And so really the cash-based model offers a greater, it offers a value-based care system as opposed to a volume-based care, which is what insurance forces a person to have to do.
Yeah, it sounds like there's more people involved in your treatment that aren't there. Like, not you or the therapist, actually an insurance person, a manager or whatever, that
Right,
may
the
not
people
know
making decisions.
yeah,
Yeah,
they're not the troops on the ground seeing the situation. They're,
right,
calling in orders and may not have the up to date situation report.
right, and they're not asking the patient,
Yeah.
what would you like to do? Would you
Yeah.
like to do the 15 minutes of sitting here with the heat on your shoulder, or they just kind of dictate it to you? And so it's that freedom of choice and the high value care, which is where you and I, originally had our when we were originally talking about, like, high value care is the main priority, and being able to live on each wheelhouse and have the patient be highly involved in the decision making process. With regard to the care, the frequency, the cost, et cetera, is where the out of network or cash based is really shines. And now with how insurance companies, so 5 years ago, the cash based PT clinics or PT model wasn't very, you couldn't see them. They weren't very popular, mostly because there's a lot of misunderstandings, and folks are just, anything medical, people think they just click into, oh, does my insurance pay? But now with the high deductible insurance policies that are a great deal more common, folks are realizing, wait a minute,
Yeah.
let's take a look at how much this is going to actually cost me. So that's where it's helping both you and I in our business model, because people are realizing that if insurance, that it's not in their best interest, either financially or as far as care is concerned, to go with the route that the insurance companies will have them take.
Okay. So that's interesting. So let's say you've got that bell curve you were talking about, and
Hmm.
somebody requires
Which
14
goes,
times, but somebody
yeah, outliers,
might
outliers out
require
here.
3 sessions, and but you have to treat them for the 7 sessions. Um, so are so kind of so I kind of feel like, so if you are getting an extra 4 sessions that you don't need, that doesn't really make any sense. Or can you tack them on later on at, once you sent them home with homework assignments for a week or two and they're progressing fine on their own and they can come back? Is there a time frame in which insurance-based model programs have to be completed in, on average,
Right.
or legally, uh, or is there some kind of system that like says, okay, you have X amount of time because we're paying your insurance, we're paying for your treatment as an insurance company? Are they determining that time frame?
Yes, absolutely. They're determining everything. And another reason why you have to have, like, just kind of dovetailing back over, the reason you have to have so many visits, like 7 versus 3, is because you only have a half an hour. If you get to see somebody an hour a week, an hour at one time, you get a lot more done than
Yeah,
2 half-hour sessions
yeah.
in a week, kind of thing. That's a little bit of a different quality of care model. But you are correct. So, and this does depend on the insurance companies, but generally, if there's like a 30-day, if there's a 30-day lapse between visits, then you have to start that continuum of care all over again, or that
Oh, okay.
yeah, or that plan of care all over again. So let's say I see you're a high level, independent, educated, and motivated individual. You got something going on. I do a really good eval on you, take my hour and a half, get everything done, give you all the information that you need to know to manage yourself until you feel like you need to come back in. And let's say it's 30 days until you feel like you need to come back in because you need a progression, because it's usually about a month before like somebody needs to progress to something significantly different for somebody with that presentation. Then I would need to reevaluate you because it's a new plan. It would trigger a new plan of care. And so then the insurance companies gets in the way of the fact that, well, no, because now you didn't have enough visits after that last evaluation. And so then they're going to not want to pay for a re-eval. And so then there's some gymnastics that we have to do with manipulating or like working with the insurance model. We'll do what it ends up generally being is the PT works for free to provide the care that the patient needs. So in the insurance-based model, if what I just said had happened and you came back and technically you had aged out in the insurance model of that prior episode of care, and you had been discharged on day like 30 and you came back to me day 31, and now I have to do a full new eval. I can't bill for that a lot of times I can't bill for that new eval. But usually what I would end up doing was be scheduling you before lunch or after at the last appointment of the day, giving you the eval that you need, and billing it either as, depending on what I can get away with, billing it either as a visit, just another visit, like a 30-minute visit, or billing it as a re-eval with a shorter time period. So that's a lot of where physical therapists historically in that setting are not doing ourselves any favor, because we're working off the clock so that our patients can get what we need. And so, yeah.
So you're
So
having
that's kind of a
to try
long
to
answer to
play.
your question.
So you're having to, in a way, manipulate the system for the patient. So
Absolutely. We're doing
yeah,
that all day long, every day, fighting with the insurance companies, trying to find ways around it, providing, and this is where, telehealth has been something that I've done, for a long time, but it's usually off the clock.
yeah,
Because that patient, like, let's say, let's talk, I mean, I could go like, this is diverting, but like a Medicaid patient in particular, it takes a month for them to be able to come in, and they've been hurt for a month and they've been sitting at home on their opioids, and then they come in but insurance will only pay for an eval. They won't pay for treat. And so but I end up treating as well, because a patient needs that information to care for themselves until the paperwork is then processed, and it's another 3 weeks before they come back. So instead of being out like, I could have, if I'd seen them right away. And this now outside of the Medicaid population this is more starkly seen, where there's a huge lag between when the patient is injured and the patient actually gets into the professional who should see them. That's another another boon for the direct access, is if you sprain your ankle on a Sunday and you go to the musculoskeletal expert, the physical therapist, on Monday for an eval, you're not going to need hardly any visits. I'm going to educate you on, you need to have early activation, or, early loading, early strengthening, gentle protection, and return to your activities as soon as possible, as well as integrating some proprioceptive strategies. And then I'm going to need to see you maybe in another week, versus you sprain your ankle on Sunday, you do the gatekeeper model,
Yeah.
and you go to the orthopedist, they do an MRI, they do an X-ray, they give you opioids, and then I see you 3 weeks later and your ankle's stuck at 90 degrees of dorsiflexion because you were scared and haven't been doing anything with it, and you're still on crutches or something like that. Now we've got 5 times as many visits that are going to need to happen, because all these impairments that have been introduced by that lag time. And so that's where the direct access and immediate access and cash-based system allows for people to go to the person who's the expert early and immediately. Like if you hurt your tooth, you don't go to the orthopedist, you go to your dentist, right?
Yeah. So it sounds like, with Medicaid, with the insurance-based model, that you're getting things done that you might not need if you could just see like you on day one. And let's say I see you on day one, and then I can have the confidence that, I can use this, or I can do this exercise, or I can put weight on it. I don't have to worry about it. And hey, I can maybe go back to work because I know what's wrong now, versus sorry, I got distracted.
Versus being scared, not using it, you crutches, all of a sudden
like
now you can't
loss
bend
of
it.
time from work could potentially
Absolutely.
be one of those factors that cost the patient more money, because now they're not making any money. So if I could see you and have the confidence to use things, then I could get back to work sooner potentially. So sorry, that's a whole different thing I didn't even think about.
Or never being out of work in the first place. And not to mention the fact that the things that you do in your life, those matter almost more than the work that you do. So let's say somebody's a runner or a cyclist, or they like walking. Getting out of your normal routine of activities and the work-life balance, getting out of that for an extended period of time is not healthy. It is not healthy to lay on the couch because you think your ankle is hurt and you can't use it. It's not healthy to have low back pain and get all these imaging studies and think that your back is damaged, when really you just have age-related changes that are normal, and you tweaked your back and you need to just get back at it. And so you just brought up the point. There's a lot of data to show that the overuse of imaging studies, and this is another area where you and I have just a lot in common. There's the overuse of imaging studies by virtue of the gatekeeper model is a significant increase of overall healthcare expenditures, just overall, and then personally for the patient. Not to mention the fear and loss of vitality and loss of participation in one's life that happens as a result of just a different mindset. You go and you have an imaging study and you think, and somebody who is just trained differently and is maybe not the right expert for you to be seeing, gives you information that makes you fearful to live your life. Like that's not quantifiable, that loss of life, that loss of participation in your own life.
So those diagnostic tests, the MRIs and things, I imagine most people have co-payments for that as well, right?
Right. And there's a lot of there's a lot of controversy. It's not because there's so much data to support that for musculoskeletal injuries, or that imaging studies, the prudent use of imaging studies are It should really be directed by a physical therapist because we're the musculoskeletal experts in the medical model. Imaging studies are correctly used to rule out a serious injury such as a fracture, or to rule in a surgery, the need for a surgery. But you should be going through, those should not be used just to, because historically for people who aren't educated or whose skills are not able to determine whether or not to suspect a fracture or rule in the need for surgery, physicians just use an imaging study just because that's what they have available to them. Because if you have all you have is a hammer, everything's a nail. And I'm not disrespecting physicians or medical doctors or the orthopedists, because there's a place for them. But their training, that's the easiest thing from them to do is let's just do an X-ray. And people think that X-rays give you information, but an X-ray really doesn't give you any information unless, in general, unless you're trying to rule out a fracture. It shouldn't be ruling in anything.
Yeah.
Generally, but yeah, the overuse of imaging studies and the fear and loss of vitality and loss of participation.
I just seen a lot of people that have some chronic issues, and they are trying to figure out what's going on. And like oftentimes they're like, they've been seeing so many specialists, and finally they go to like the orthopedic, and the orthopedic's like, well, we need to do MRI or X-ray at this point. But they've had this pain for 6 months, 2 years. Like, I feel like, what is that going to tell? Like, is it really going to make a difference? Like at this point, I know as an athletic trainer, if I have an athlete go down and I saw an acute injury happen and it's swollen and there's like trauma and it's black and blue and they're not moving, I'm like, they probably need some kind of diagnostic. But if they've been dealing with some chronic stuff, a lot of times in my history, I just teach them how to move, and then they start feeling better. And the X-ray, the MRI, it's still going to look the same, but now their pain's
it's
gone.
Not diagnostic.
Yeah. Yeah.
Right.
So,
no, you're right. And then, yeah. And there's also ways. And so exactly what you just said, and there's just really good data. The image, especially when it comes to now we're a little bit off topic, but especially when it comes to spine related symptoms, the term degenerative disc disease is fear inducing, and it makes you think that there's something wrong.
Sounds scary.
It sounds frightening. And that's just because that's just how that's grown up, because we haven't been able to look inside the body. It's like 50 years that we've had MRIs. And so the medical model is to apply, disease to anything that doesn't look pristine, when in reality, it's just age-related changes. So yes, you hit the nail on the head here. In the absence of trauma, there's no need to do an imaging study to rule anything out that's more sinister, unless you're suspecting perhaps a tumor or something medical, right, not something that's musculoskeletal. And so, yes, how many times have you, and physical therapy has been one of the, the leaders as far as like doing research with regard to the overuse of imaging, the overuse of opioids. And now finally there's attention on that. But yeah, you're right. If it's hot, fresh injury, and there's indications of a fracture, by all means you get your imaging study. But otherwise,
in that case, yeah, I'm kind of the gateway person as an athletic trainer.
Yes,
so
absolutely.
I'm saying, hey, let's go to a physician that can order an MRI or the physical therapist, and that's what it sounds like you're taking the place of. You can determine for the person on day one, hey, let me do some tests, let me check this out. Well, you know what? I'm kind of worried it might be, something else. Let's send you to the next step, versus going to the physician that, yeah, let's get you an MRI and then let's see the physical therapist. But then maybe that MRI wasn't needed because the physical therapist could have superseded that whole process.
More often than not, in the absence of trauma, imaging studies are more often than not they are unnecessary. But you forget that when you're on the field, as an athletic trainer and you're determining whether or not that person needs to go in for an imaging study, an X-ray, you're forgetting that you're specially trained to make that clinical decision. You've learned special tests and assessment skills to be able to say, ooh, that hot, fresh ankle, you probably ought to get that looked at,
Yeah.
versus hot, fresh ankle, walk it
So
off.
as an
You'll be all
athletic
right.
trainer, I can assess, I can't evaluate,
Correct.
whereas you can evaluate and as a physical therapist, can you make a diagnosis?
Yes.
Okay.
Yes. Absolutely. Yes.
Where my
So,
role is a differential diagnosis where I can say, I think it's one of like three things. And then
mhm.
I think it's either A, B, or C. And then you determine, well, it's B, and B requires further intervention, whatever. Um, okay, cool.
Yeah.
So
Yeah.
it didn't get too off topic because we're just talking about how all of this is increasing the cost for the patient because they're not seeing the right person immediately,
Mhm.
which is
Mhm.
in this case a physical therapist. So we're talking about we were kind of talking about the costs. So we have costs from um, let's talk about the treatment times with a traditional insurance-based model. Are there any data sets that show that, hey, if I have insurance, this third party saying do this one program in 6 weeks, that's your treatment time. But if I go to the physical therapist earlier on and I'm working with that physical therapist for an hour 3 times a week, is there anything that shows that treatment time is compressed?
Oh,
Um,
absolutely. Yeah. Yeah. If you go to the right person who diagnoses and treats you soon, rather than going through that traditional model, and having delayed care, early care to the right person reduces overall costs. Absolutely. And then we can kind of dovetail on you and I and our collaborative model where, uh, where our arrangement allows us to operate at the height and breadth of each of our skills and then hand off to and work collaboratively so that we can reduce overall costs. My costs are higher because, and so instead of seeing, since we communicate and collaborate, we reduce the amount of times that I need to be seen, that a patient needs or a client needs to be seen by me, because you and I are talking and working together. So if I'm able to do a really good eval on a patient, it reduces the number of costs, because historically, like if I'm just working on my own, I'm going to see the patient for the eval and then I'm going to see them for the follow-up visits. It's a higher cost for the follow-up visits for myself based on my credentials, et cetera, versus somebody coming to your clinic. But it's not necessarily, people don't necessarily need to see specifically me and my physical therapy skills. And that's where there's, some ego reduction and just realizing that it's the patient that we're concerned about the most. And I think that's where we're the most innovative, because we're checking each other's, we're checking our egos at the door and placing the patient care first.
right.
So we're reducing the number of times that people need to see the higher cost professional, but I'm actually then able to fully do, to the extent of my training, and to do a very thorough job, which can inform further treatments. And so then, because I'm able to do a really good eval and get really good thorough information, that can inform you all, and you can be providing more targeted, specific interventions, higher value care, which can ultimately have better results and fewer visits through that episode of care.
Right.
But also, because we're working together and we know the patients so well, you're building relationships with them. And so just much like the dentist, the next time that person, because people have musculoskeletal stuff, it kind of creeps up. Next time they have something happening, they can come on back. So we keep people, it's building relationships we're the musculoskeletal experts for life rather than one episode of care. So if you come back to me, we come back after we've spent some time together and we know the patient or the client, then they don't have to retell their whole story. There's like layered information that we learn about the patient every time they come in, and it just becomes more valuable, more valuable, more valuable. The better we know that patient, if that makes any sense.
Yeah, it makes a lot of sense, especially, if maybe they leave for a while, they go see somebody else and they have to tell their whole story. This other person is now having to learn about them and maybe has to go through a month of treatment to catch back up to their knowledge of that person, where if they go back to you, you already have that knowledge and that baseline education on what they need and um, what will help them to heal a lot faster, versus having to start all over every time. That makes a lot
Right,
of sense.
because and like we all know that patient care is not just about your diagnosis. It's about your lifestyle. It's about your personality. It's about your preferences. Like all of those things are really important in being able to provide high value patient-centered care. And so if you know the patient or the client, you can provide that care in the most unobtrusive way and effective way immediately and throughout their episode of care, rather than fumbling around trying to figure out what works best for that person. And so that's where that collaborative model really works nicely.
Yeah, I've had a lot of people come to me. I've seen 15, 20, 30 professionals, whether they're doctors, chiros, massage therapists, acupuncturists. And it just seems like they've been told all these different things, and in certain situations that might have been the right thing for them. Or maybe they needed acupuncture, or they needed that specialized massage treatment, or whatever, the chiropractor was working on them with, because if that one professional had continued working with them, maybe they would have progressed them to feel better. But I think I work with so many people that have been bounced around all over the place and never have cohesive interaction of all their their healthcare professionals in one place. If you took all those specializations and said, hey, you do need acupuncture here, or this chiropractor does some adhesion work, which is amazing, and it's exactly what you need right now. But if you had somebody, or if you have all those people like putting together their forces with that patient, then that treatment time would be more directed in the right direction, and it sounds like it'd be a lot shorter treatment time too. So so we have shortened treatment times, lower cost. So how does what you were just talking about lower the cost for the so if you can see them on day one, evaluate them, your costs are going to be a little bit more expensive for that one evaluation.
At the outset,
Right.
yes.
So I think from what it sounds like is you're spending a little more now, but you're getting far superior results, faster treatment, shorter treatment times. So back to where I paid $1,800 over 4 months. Potentially, if I spent $700 in 2 months, where I was getting just seeing you, and then you recommended work with this personal trainer once a week to do to build on the program that we went over. They're going to do everything that I went over on your evaluation, and then I want you to go see this soft tissue specialist once every 2 weeks. And now you're starting to put together the right people for the job to shorten their time. So now I spent $700, but I'm better in 2 months. And
Right, exactly. Yeah, and so yes, and so you talk about like you bring up a very good point of it, and it's nothing against the different professions that these people have gone to before they finally land in your space. It's not that the professions themselves are not effective. A lot of times, what's really important is the timing of when those professionals are in that episode of care or in that patient's life.
right.
And so like what you just said, so it's that what really just, and in other medicine, in medicine in general, the specialization is very important. But what folks are realizing is that it takes a village, it takes a team. And so historically there's just been a lot of siloing, And like our first conversation, we talked about co-opetition, and in it's easy to want to keep your patients because you're afraid to refer out to somebody else because you might lose that patient or that client. And I completely get that. We're business people. We're trying to, make do with the best, and do the best we can with what we've got. But at the end of the day, the sharing and the collaborating and bringing in different professionals in the time that that patient or that client needs them is critical. And so that's where that co-opetition or that collaborative model is really important for improving the value, being able to provide high value care for a patient. So getting a massage, for instance, when you have an acute injury that hasn't been diagnosed, might make you feel better for a little while, but it's not diagnosing and addressing the cause of that injury. Whereas getting a massage after somebody like myself has been able to evaluate and diagnose that injury, and getting the massage at the right time, that can not only decrease the patient's symptoms, but it can also increase their function because and then bringing in a personal trainer to provide the information about strengthening and improving their movement patterns and all that at the right time is going to increase everyone's effectiveness because they're being brought in at the right time, and then also reducing the overall cost of the patient because they're not getting repetitive treatments that are non-helpful. But also what's really valuable is to have consistent messaging among all the people that there's a person is seeing. If
Yeah.
you get different messaging from each professional that you see, that patient doesn't know what to do. They don't know who to listen to.
Yeah.
And sometimes it's just that person who's the most persuasive, which doesn't necessarily mean that they're most qualified.
Yeah.
And it's hard to be humble and admit if you don't know other people who are like-minded professionals that you feel comfortable and safe with as far as their ethics and the way that they treat their patient, you're going to be less apt to want to refer out and consult with if you don't know those people. And so knowing what different professionals' strengths are is what we've got with the
Okay.
best day is we all know what each other does. We know what each other's strengths are. And if I'm recommending somebody go to see the massage therapist, I'm talking to that massage therapist ahead of time, and we're
Right.
using consistent messaging. We're looking at the similar issues, and we're all on the same page instead of having all this discombobulation, which is very inefficient and results in higher costs overall and a great deal more frustration.
Yeah, and it just seems that the patient is making those decisions. Maybe they heard about this specialist from their friend, and they've tried everything else. So they're going to go to this specialist. Maybe that specialist was going to be great for them at a different time frame in their injury history, but maybe right now isn't the right time. So they go to see the specialist, and they have a great reputation. They're that you walk in, they've got a beautiful facility. Like, oh, this guy knows what he's doing. This is where I need to be. And then you get that treatment, and it may or may not be the thing for you at that time in your healing process. Maybe at a different time. Maybe if they saw a physical therapist that talked to the specialist and was like, hey, we're working on A, B, and C. Can you reinforce A, B, and C? And all of a sudden now, like you said, everybody's working together versus that patient just like, oh, I heard this person was good, I'm gonna go see them. So that's what I see a lot of is people are going to places and other professionals because they heard they were good, or they've read about them online, and they had a nice website where that's not necessarily, they're not the patient isn't the expert. They need to talk to the experts to determine where they need to go. So if you come into a collaborative model, you have the whole team like, hey, I think we need to, like I said, we're kind of going back around again, but we're
Yeah.
having multiple disciplines determining when those specific disciplines are right for you. And so ultimately, you can still get that treatment, but maybe let's wait a few weeks because we're doing this other stuff right now. And that'll be more effective when at a different time frame based on your level of healing or where you're at with your injury or whatnot.
Right, coordinated care.
Oh,
And
that's
you
good.
you
Coordinated care. Yeah.
yeah, and what you also mentioned was we need to make sure, like, and we're kind of, it's in the subtext and we're assuming it, but it's patient. The patient is we're alongside the patient making decisions based on what is
Yeah.
in their best interest. We're
Yeah.
considering all of the variables that can confound or or increase the patient's ability to live their best life. So if there's, people have different levels of finances, and myself as a physical therapist, especially coming from the insurance-based model, a part of my job is to be aware of and work within the fiduciary part of that patient's care. And so, being able to talk, like, people are afraid to talk about finances, but like opening up that conversation from the beginning of where, and being frank about it, because historically it's easy to lose somebody because they're like, because not having a conversation or being sensitive about that variable. If the ultimate goal is to provide quality patient care, we need to do that. There's the, like you say, like, there's that James Brady, there's
Tom
the
Brady.
optimal. There to oh
James
Tom,
Brady.
oh
Who's James
oh God,
Brady?
he was Ronald Reagan. He got shot anyhow.
Oh yeah, yeah. That wasn't
I'm
the
so not
quarterback
a
for the
sports
Patriots,
girl.
and now the
That's
Bucks.
a long. Yeah, but you have, there's the, it's just like life is, we
Right.
have the, ideally we do this, but if somebody's here, we don't want to miss that person. It's like those Medicaid patients.
Yeah.
If you're patient-centered care, that patient is they're not having that care imposed on them. They're having that care, the care plan being, they're a team member in that care plan. What do you prefer? What works best for you? What are your concerns? How do we work around and with it? So again, we're building relationships, and anyone that comes through your doors, they're a part of the Best Day family, where it's a long-term relationship. We want to keep you for life. And because of this collaborative model and coordinated care, that's possible, because as we're building the people that are affiliated, there's nothing that's going to be neuromusculoskeletal that we can't at least inform or advise about. And that's
Yeah.
kind of like that ultimate goal. That's that's another podcast for sure. But
Yeah. So yeah, so to kind of sum up everything we talked about, so the main gist of everything was um, insurance models versus cash-based models. Insurance models tend to be traditionally like, oh, will they take my insurance? That's kind of a cultural thing. I know a lot of people go call up here and like, do you take insurance? And it's just, but I'm hearing less and less of that. I'm hearing more and
mm-hmm.
more medical professionals, chiropractors, physical therapists, doing cash-based and being very successful from a business standpoint. And we go in, most of us do go into this because we love helping humans, but then we realize we have rent to pay and power bills and things. So we do have
Yeah.
to run a business. So I do notice that the cash base in programs are usually very successful in that
Mm-hmm.
um, the treatment times are less and the patients are happier because they don't have to come in as much. And what I know, I've got some specialists that I go see periodically, and I know that when I go in there, I'm going to get their undivided attention for an hour,
Right.
and I'm going to get exactly what I'm paying for. And I know I won't have to go see them again for a few months versus going out and saying, oh, does insurance take this? Okay, great. So I'm going to stick you with Frank back here who's smoking a cigarette on his break, and they come, work on your knee, and you have to go see him 20 times, and I'm still in as much pain 20 times later, but my insurance covered it. Uh, so that's kind of seems to be the overall trend of what I'm seeing now. So that's why I was really excited to hear that you are cash based, because like I said, it seems to be a better model. And then it's kind of where we're going with the virtual platform and the collaborative model where, yeah, it's going to be a little more out of pocket at first, but we're here to fix you as quickly as possible, because if we make you happy in 2 sessions and you're feeling better, then that's good for my business, because now we've built a relationship. You're going to go tell friends about us. We're going to grow our family, and then I can do what I love to do, which is heal people, and I can heal more people, and I don't have to worry about, hey, give me an extra $10 for the session, or ooh, I can't see it today because you can't afford it, because we've already fixed you. And that's the main thing, is giving people the tools they need and guiding them in the right direction, in order to help them heal faster. So yeah, that was basically everything that we went over today. Did you want to sum up with anything?
Yeah,
Other?
yeah. Yeah, absolutely. Just to summarize it, insurance-based care is volume-based care. It does not in any way, shape, or form guarantee quality.
So
It's
you're basically a cog in
volume-based.
the wheel. You show up
Yep,
and okay.
absolutely. Whereas the cash-based, out-of-network, direct pay, whatever you want to call it, our model is the pinnacle and the foundation upon which it's built is that it is value based, patient based care. And like you just kind of made me think while you were just talking, is like, if a person's main concern with regard to their health is how little they pay, how backwards is that?
That's definitely a messed up cultural psyche that we have.
And that's what the insurance companies have done to us.
Yeah.
How little do I pay for this? It's my health, my life, but how little do I pay? And so, but that's at the end of the day, insurance is volume based, does not guarantee quality. Cash based is based on quality. Because if we don't give quality care,
Yeah.
you're not coming back.
Yeah. And just to kind of
And we don't feel good about it.
right. And that's not to say all insurance-based treatment is bad. And
Right.
that's definitely want to, say that out loud, because, I had amazing treatment. I loved my treatment. I was very satisfied with the success, and I did have to pay out of pocket, and it did take a long time, but I probably fell into that insurance trap because I could afford $120 a week at the time. I couldn't in
Not a
my
lot of
head
people
maybe
can.
justify $400 a week to get it done a little sooner. I mean, I had a really traumatic acute injury though, so
Yes.
I might have been a little bit different case, because when you completely tear your shoulder off your body or your arm off your body, it's going to take a little time. So I probably needed
Yeah.
that time, but yeah, yeah, we're definitely supportive of any professional that is there to help you heal, whether or not they're constrained to insurance, a third party, or
Right. And I will, people contact me, and if they really need to use an insurance-based physical therapist, I do have and am building a network of like-minded
yeah,
professionals to identify those folks who are working in the insurance model, which is not, you are correct. It is not bad at all. It's just there's like with any profession, there's a strong amount of variability with regard to the professional. And so that's also kind of a side of what we're doing too, is building that network outside of that cash based. Because if a patient or client needs to use insurance, then by golly, I'm going to refer you to Russ, who's a damn good PT, and he takes your insurance. And so that, yeah, you bring up a good point there. It's not just about putting, it's that client based. It's like
right.
what works for them,
Yeah, they're
and
like the
doing
fiduciary
everything.
or our responsibility to talk with them about the finances, and
Yeah,
that's
and to find and to help them get the best care that they can in their personal circumstances. And so, yeah.
awesome. All right, well, I think we covered pretty much everything today. Thank you, Tonya, for your time,
Of course.
and thank you everyone for listening, and we will catch you next time. Have your best day ever.
Best day ever.